Hi, I'm Dr. Tom Babu, and I'm the consultant endocrinologist and medical director at Silverline Hospital, Kochi. Today, we're going to start a new video podcast series titled Everything Diabetes. And what we'll be doing in these podcasts are that we'll be going into everything that you need to know about diabetes in some detail and from the absolute experts in the field of diabetes that there is. So today, to kick off our Everything Diabetes, we have Dr. Karthik Subramaniam with me. He's the consultant endocrinologist, Adult and Pediatric at Silverline Hospital. He's actually a good friend and colleague who works very closely with me at Silverline Hospital. So Karthik, welcome to Everything Diabetes.
Thank you, Dr. Tom. I'm very pleased and very happy to be here, and I hope we'll have fruitful discussion so that it will be helpful to all our listeners.
Absolutely, Karthik. Let's dive into our discussion, Karthik. So, straight off, what I wanted to ask you is, you must have noticed the ICMR data, which got published very recently, which showed an alarming rise in the prevalence of diabetes. On an average, we are looking at something like 18-19%. But some states show such an increase, like Kerala, Punjab, and I think Goa, where they showed 25% of the population being diabetic. So what do you think is going on here?
Very pertinent question. I think I would just split the answer into two. Answering your first part of the question, that is the increasing prevalence of diabetes. We know we are one of the fastest developing major economy. You could just see around ourselves. That there are lots of urbanization going on, and the rapidity or the pace at which this is going on is very unforeseen. So such an rapidity of growth is not able to cope with our genetic makeup. The changes which has been there from industrial revolution for past 200 years is happening within past 2 decades. So this results in lot of stress, not only in ourselves or in the environment, but also in our genes. So this is what we call epigenetic changes. So this is, I think, one of the foremost factors that is driving the prevalence up. And secondly, as a result of this urbanization, easy availability of high calorie diet, the drastic reduction in our physical activity, and the pollution, which is a byproduct of such urbanization. We are aware of all the minimal effects of pollution, such as noise and so on and so forth, but air pollution and microplastic related pollution, and there are something called endocrine disruptors. These are small molecules that will interfere with our endocrine system and results in hormone changes. So such increasing levels of endocrine disruptors also might play a role in increasing prevalence of diabetes. And when I come to your second part of question, that is specific states which have higher prevalence than other states, I think it is more as an extension of the already detailed process which I had told initially. That is, if you look at the states like Kerala, the urban-rural divide is almost diminishing. You can't pick and choose a village, so-called village in Kerala hereafter. So that, along with increased affluence of the society, and also the patient education, that is the patient awareness, the literacy rates, patients are seeking healthcare. They themselves want to be tested. So I think this in total would result in higher prevalence in specific states. Dr. Tom, as a practicing endocrinologist, I'm sure you would be looking at lots of patients with diabetes. But generally, there is a perception that diabetes is a homogeneous problem. In the sense, someone comes with a report of fasting and postprandial sugars being high, you give a medication and things get sorted out. Is it as simple as it seems to be? Is diabetes a simple homogeneous problem, or is there something more to it? As an endocrinologist, could you just give some more insights into it?
Yeah, I'm often faced with this conundrum, which is this when you look at the general public, they tend to bunch all these things about as just diabetes and just about increasing blood sugar values. So what often fails them, or we fail to notice, is that there are many forms of diabetes. The most common being the convention, which is that you imagine when somebody says diabetic, what comes to your mind is a middle-aged 45, 50-year-old
Exactly.
person, male, female, equally, with, they are obese slightly, they have weight issues. They also often have hypertension, cholesterol problems to go with. And altogether, we know that this puts them at risk of cardiovascular, heart attack, strokes and all that, and kidney failure and so forth. So this is why we're worried about this population. But it's important to understand that things are changing now. It's just not that typical roly-poly, 45-year-old presenting with diabetes now. It's that we see all shades of diabetes. So one is that we are starting to see more and more leaner individuals sometimes who are presenting at a much earlier age, at maybe even before 30 years of age. And maybe it's just that the sheer magnitude of diabetes, we're starting to see so many diabetics that all these fractions are beginning to pop up. And the importance of identifying these fractions is that each of these people need different treatment protocols. So you can't treat like that typical type 2 or that approach with these lean individuals, because then you'll completely miss the boat. Then you have a slightly rarer form, which as type 1 diabetes. Now, type 1 diabetes is mostly seen in children, but you can see it in adulthood also. It's like 25, 30 year olds. And so often the diagnosis can get completely missed if you're holding on to that image of a diabetic who is obese, middle-aged, etc., etc. So, and in children even now, you're starting to see, earlier the convention was that in children means they are type 1 or they are lean and they manifest at 6 years, and they are absolutely insulin requiring. But not really anymore, because you're starting to see obese children starting to show diabetes at a very early age, something that we never saw in the past. So therefore, I think it's important for our public to know that, one, diabetes is not to be taken lightly. It is not just a lifestyle disease, which you can just, take it lightly like that. And secondly, the whole spectrum of the disease comes in various hues and shades, and each of them may require a different kind of approach altogether. So if you're going to mismanage one form of diabetes thinking that is the other, then we are completely misled in our approach. So I think it is important that everybody knows that it's not just diabetes, and diabetes can come in many hues and shades. So we spoke about the various types of diabetes that there is, and COVID has put a spotlight on diabetes. And if I were to put it, I would say it's exposed the fabric of diabetes. It means we've understood diabetes more after COVID. So I think it's an interesting discussion, and people out there want to know how is diabetes changed, or how has COVID changed our understanding of diabetes? How are people living with diabetes after COVID?
True, highly pertinent question, sir. Basically, what has happened is that COVID, as a result of COVID or post-COVID, there has been lots of increase in incidence of diabetes. Incidence by meaning means that there is new onset of diabetes after the infection. So that is one thing which is very important. Why? Because this is like one of the infectious agent that is going to cause new increase in diabetes. So the number has almost 20-30% increased in past 2 to 3 years. So, and one important fact that we had understood through these few post-pandemic years is that probably virus per se by itself might have a direct effect on pancreas, directly destroying few cells in the pancreas that are known to produce insulin, as a result of which there is insulin deficiency, or probably it might have triggered some immune related response, as a result of which there might have been destruction in pancreatic so-called beta cells that produces insulin. So that might be one of the reasons is what we understand of it, but not to undermine other causes, especially the usage of medications. While patients were in hospital or when they were being treated outpatient, there was lots of use of steroids, and we know that steroids are one of the potent medication that increases the chances of high sugars, and probably majority of them might have recovered from steroid induced high sugars, but there might have been a proportion who had persistent high sugars even after withdrawal. So that is another reason which I think would have contributed to increased incidence of diabetes, and not to undermine the effect of stress, which the COVID has put everyone including us on.
Absolutely.
The physical stress, the mental stress, the social stress, and financial stress, of course. So, and that by no means has to be taken very lightly. And I think one of the last reason would be probably because of the limitation in physical activity and lifestyle restriction, that people who were doing everything outside their home were limited inside home for probably 1.5 to 2 years, and now people are gradually getting out. I think that might also be one of the contributory factors.
Absolutely. Stress certainly is, I think, to my mind, a very important risk factor here.
Dr. Tom, the other day I remember you discussing an article in the week regarding Ozempic culture, the new medication which is talk of the town. Could you just in the interest of the people who are listening, our listeners, could you just elaborate on that?
I'd love to, because I'm also particularly taken aback by that article and the term itself, Ozempic culture. So what really this is that Karthik, the incretin based therapies where so initially we had exenatide. So these are basically injectables used to treat diabetes, but it's not insulin. And what we also discovered is that people lose a lot of weight when you take these injections. So it started off with exenatide, which was to be taken twice weekly. Then we got liraglutide, which you take once weekly. Then you got Ozempic, the Ozempic culture, which you take once weekly. So what happened with Ozempic really was that even from the studies, we knew about this almost 3-4 years now, that people lost substantial amount of weight when you treat diabetes with these agents. So much so that I heard that the company that makes it, Novo Nordisk, based in Denmark, the GDP of that country went up because the sales of Ozempic just went through the roof when people understood that you can lose substantial amount of weight by taking this injection.
And medication is in the short supply also.
Correct, yeah. And so therefore now the celebrities in Bollywood and maybe even Hollywood, I don't know, but this week article mentioned Bollywood, where these celebrities without prescriptions are taking this drug because it's known to produce a lot of weight loss. And I had patients randomly call me and ask me, how much is it costing here in India? In Dubai it costs this much, there it costs this much, so can you send some Ozempic? So I'm like, who gave you a prescription? No reply. So that's the way things are going. But I think this is a good occasion to talk about these newer drugs, what it can do. Certainly, incretin-based therapies are the way forward, especially in our obese diabetic patients, mainly because it's, in addition to blood sugar control, it's shown to do many things like heart protection, kidney protection, so on and so forth. So therefore, what our listeners should understand is that there's a sea change in the way diabetes is being treated today. And people should be aware that what used to be the case maybe a decade ago is not how we doctors look at it today, because we are always asking on what extra. Okay, blood sugars is a given, we have to control the sugars, but in addition to that, can we protect the heart, can we protect the kidneys, how do we make, which is this drug going to make our patients live longer? Is it safe for the kidneys? Is it safe for the heart? All these considerations are in front of us before we start treatment. So therefore, I wouldn't recommend anybody taking these medicines without a proper prescription, without supervision, without a doctor to actually endorse or give a prescription for these agents. No, that is definitely a no-no. But having said that, we need to understand that these are exciting times for a diabetic patient, and now we have an oral form of the Ozempic in India. In India, we don't get Ozempic, but we get the oral form. So we are better that way because we got better drugs now when compared to the rest of the world. Our diabetic patients live in very exciting times to my mind, because we spoke about the newer drugs that there is, which can produce a lot of weight loss. And you also have new technologies coming to make a diabetic patient's life much more simpler, much more manageable. And I think we should discuss about that, because I think our audience need to know about this part of diabetes. And diabetes is not all that, sad or difficult. I mean, we can, because technology is here to help us.
Absolutely true, sir. As you were pointing out, it's not a sad story anymore, in the sense there are lots of advancements in diabetes, especially for type 1 diabetic individuals who are known to be insulin deficient and who are almost always dependent on insulin. As you were telling, the new advancement is called hybrid closed loop pump. These terminologies might seem to be a bit fancier, but each and everything has its own meaning. Hybrid meaning you will have to put in some more manual effort into it. Closed loop is the one which we consider generally standard, in the sense closed loop pump is the one which detects sugars by itself. It will communicate to a pre-programmed algorithm, and the algorithm would give back the result, in the sense it would determine the rate of insulin infusion. So basically this pump has three components.
It's all in that pump, isn't it?
Exactly. So there is a component called sensor that will continuously monitor sugars, and that will communicate to an algorithm that is present in an iPhone, and from that it will be communicated back, everything wirelessly in a Bluetooth connectivity manner. It would be communicating back to the pump, and that pump would decide how much insulin, how much micro units of insulin to be delivered at what point of time and in which manner, so as to keep sugars well under control. Usually we generally say that sugar levels of between 70 to 180 is the in target range. So this pump is designed in such a way that if there are any fluctuations above or below, it is programmed to reduce the fluctuation, and as a result there will be seamless sugar control in individuals, especially in type 1 individuals, but also even type 2 individuals are also
benefited from this.
They might also be benefited from this pump.
Sure. Karthik, I see more and more people use that sensor that you wear behind your arm. So I see the usage of it go up steadily. So would you want to just enlighten our audience on that flash glucose monitor that we've started using more and more?
True. Exactly, sir. Why? Because I think, as you had rightly pointed out, the usage by itself being high means that there is a comfort level with that, and people are more aware with respect to that the monitoring system, the sensors. It is called continuous glucose monitoring systems, and it comes in several forms, several shapes and several lifespan, in the sense there are certain things for 7 days and certain things for 14 days. But what is more confirm or more concerning or more heartening is that people get to know real-time data, real-time information regarding their sugars. That is one thing. As a result of which, you are more empowered, in the sense once you know your sugar during any part of the day, you will be more inclined to take any decision regarding that. For example, you will be knowing how much sugar is going to rise by taking XYZ of diet, or how much is going to reduce by doing XYZ of exercise, so on and so forth. So the more the data you get, the more empowered you are, the more you are controlled, the more you feel control with the diet is. So that is one thing in which it is helping a lot. And as you rightly pointed out, it is not specifically designed for X, Y or Z people. Anyone with diabetes can have it. They can know their degree of control with the sensors, and it could be used for 2 weeks and simple and easy to use, integrated seamlessly with several apps, and more importantly,
and you can lately get it on the iPhone also.
Exactly.
Earlier we were using a reader, but so that was confining a little bit, but now you can get it on your iPhone.
Integrated to our
Mostly
phones.
iPhone. No, I think all the phones.
Yeah, even
with
Android.
a certain level of sophistication is
Exactly.
I think what the requisite is. But from a certain level of sophistication, I think most phones are applicable. No,
Exactly.
That's how it is.
Exactly. And one important thing which I just wanted to highlight is for those who are pregnant. This category of women who are going through lots of stress during pregnancy, they are much more inclined to control their diabetes because they are empowered with lots of
And
data,
also
especially midnight.
Earlier they had to jab themselves
Exactly.
several times, 5-6 times. Now
Exactly.
they
Get
don't
up in
need
middle of night and jab
true.
yourself. So all those are done seamlessly now.
Correct.
Dr. Tom, these days we see lots of advertisements and lots of media hype regarding so-called lifestyle medicine, wellness medicine. And with respect to diabetes, that is, I think it's pretty important because they emphasize on the fact that you could cure everything. You could come back to square one on that treatment. Is it true? Is it absolutely true that diabetes could be reversed, or can we all put all the diabetes in single basket, telling that everything is well and done after this crash course of few weeks or so?
So you touched on a very controversial topic, and I'm afraid that I'm going to have to disappoint some of our listeners with my answer. So I think the premise should be that diabetes can be managed and not cured, right? So then that leads to another terminology, which is remission and cure. So what is remission? Remission is you're just going to put something into an abyss, or you're just going to press stop for some time. It's not going to go away. So that is remission. And cure means that you've completely cured. So diabetes cannot be cured. Let's just understand that straight up. Then comes the remission part. So suppose our diabetics, some of them, not all of them, were to go through an unimaginable kind of strict regimental lifestyle, which to my mind I think will be very, very difficult for 9 out of 10 people to do. And if somebody can follow such a rigorous lifestyle, then maybe a percentage of people can go into remission, but then it will come back at some point, because it is impossible for somebody to live like a machine. And humans, as we are fallible, means we come with imperfections, and that's what makes us human. We can't be a machine. So these crash courses look at people as machines. They think that no, they have to eat only salads, eat only this, do only this, keep monitoring your blood sugars, how many ever times, and all this. So literally like machines. So I refuse to see my patients as that, and I often encourage my patients to live in total, means with all their fallacies, little bit of indulgence here, there. This is how life is. So therefore, I think our audience should understand one thing clearly. There is a diabetes remission. Diabetes remission is not cure. It means that at some point it's going to come back, show its head again, and we have to be humble enough, forthright enough to accept that. And yes, if this cure thing is getting us thinking, or getting our diabetics to come and discuss this with us, so be it. So it's a good thing that this drives them to us. But I think the message that we ought to give them should be very, very balanced, because it's one thing when we say this, they get very disappointed because they come with a lot of hopes to think that, okay, they do this and the diabetes will get cured completely. So there will be that element of disappointment that there is, but I'm ready to deal with that disappointment because I don't want to mislead my diabetics in thinking that there is a cure for diabetes. So Karthik, we covered a lot of ground here today. But in summary, if you were to give one message to our audience about diabetes, what would that be? What's your favorite?
So I would rather say that we are living in a world of information, lots of information readily available, easily available in just a touch. So
but not everything is credible, isn't
exactly it? So that is what I would just want to emphasize upon, because when there is lots of options available, we are easily tangible for misguidance, or easily we could be misled, and that is where we'll have to have our head straight on that. We'll have to get information from credible sources, from authoritarian sources, and which are approved. So that is where I think people have to spend some time knowing which is credible, which is legitimate. Writing a blog or getting some YouTube video is quite easy, even for a person who just has few bits and pieces of information. But getting a credible information is what is important, and that is what I just want everyone to if you want me to give a single message, I would rather say that legitimate information from a credible source is what you'll have to get, especially with respect to lifestyle disorders.
So knowledge is everything insofar as diabetic patients are concerned. Yeah, that was what your message was. And in a funny way, you brought it all back to everything diabetes, and that's what we're trying to do in these episodes. And so Karthik, I really enjoyed talking to you. Had a great time talking about diabetes. And I'd like to thank the audience for listening in, and please look forward to more such episodes on everything diabetes.